This is Michael Altos recording part 2 of the Hemostasis section of Barish chapter 16. So now we're going to talk about the clinical aspects of coagulation. And we're going to start by reviewing the kinds of questions we need to ask when we evaluate a patient for any potential problems with their coagulation system. And it starts, of course, with the medical history. So we want to know if the patient has any history of excessive bleeding, which could occur with surgical or dental procedures or blood draws, or even just with brushing or flossing their teeth or with menstruation. Patients may describe a history of common or recurrent nosebleeds, blood or blackened stools, blood-tinged urine, or easy bruising. It's good to ask if patients have ever had a blood transfusion and then follow it up with why was that needed. And we may see some differences in the medical history depending on whether the problem was with primary or secondary hemostasis. Patients with issues in their primary hemostasis may describe superficial bleeding and bruising in their skin or their mucosa, whereas problems with secondary hemostasis tend to be more severe, with deep tissue bleeding or hemarthroses, that is bleeding in the joint, hematomas, or outright hemorrhage. There are a number of evaluations that can be done in the laboratory to assess for problems in coagulation, and we're going to review a few of those now. The first is the platelet count, which measures the number of platelets, but it says nothing about the function of those platelets. A normal platelet count is between 150 and 400 times 10 to the 9 platelets per liter. Thrombocytopenia is defined as being less than 150, but practically we don't usually see surgical bleeding, if the platelets are healthy, until the count gets below 50. And spontaneous bleeding usually doesn't occur until 20 or maybe even 10 times 10 to the 9 platelets per liter. What can cause the platelet count to be so low? Well, there are many causes. Of course, they can be consumed by organs in the body. They can be destroyed. There can be splenic sequestration, as well as failure to create new platelets. There is a laboratory test called the bleeding time. This is an old test. It does assess both thrombocytopenia, that is platelet count, as well as platelet function, but it's a very non-specific, non-reliable, and relatively unpleasant exam where they basically make a cut in the patient's arm, and then they count how many seconds it takes for a clot to form. This is not considered a standard test anymore. There are more sophisticated tests of platelet function analysis, and platelet aggregometry, and these can distinguish between patients who are on antiplatelet medications or other platelet dysfunctions. These tests do exist, but I wouldn't consider them to be very common tests or very rapid tests available for us in our acute care settings. Other laboratory evaluations, now away from the platelets. When we're talking about coagulation factors, we of course know about the PT or the INR. PT is the prothrombin time, and it tests the extrinsic pathway, which really involves a lot of different factors, but uniquely it tests tissue factor and factor 7, two things that exist only in the extrinsic pathway. A normal PT is about 12 to 15 seconds. The INR, which is an index and it's normalized, usually is a normal value of about 1.0. And the way this test works is they just take tissue factor and add it to the patient's blood and watch it clot. Patients who have vitamin K deficiency or who are taking Coumadin or have liver disease are likely to have a prolonged PT or INR. The PTT tests the intrinsic pathway, which again contains a large number of factors, but the factors that are unique only to the intrinsic pathway include factors 8, 9, 11, and 12. A normal PTT is about 25 to 35 seconds. The way this test works in the lab is they add a negatively charged surface to the blood sample, like a phospholipid, and they measure how much time it takes for the blood to clot. Who has a prolonged PTT? Patients who are taking heparin, patients who have antiphospholipid antibodies, patients with hemophilia or von Willebrand's disease. Interestingly, patients with polycythemia will also have a prolonged PTT because the proportion of their blood that is cells is high, and so the proportion of their blood that is plasma is low, and so it will seem like they have a deficiency in factors, when really they just have an abnormal ratio of cells to plasma. For the same reason, an underfilled collection tube will also register an abnormal PTT. And that's why the lab is really particular, more than any other test, that those blue tubes be filled to the line. I also want to point out to you that factor 12 and kallikrein, when they're deficient, they can prolong the PTT in the lab, but they don't cause any clinical bleeding. There's a related test called the ACT, the activated clotting time. This is something we see quite a bit in the operating room. This is very good for measuring heparin activity or protamine reversal, but it's not as sensitive to other deficiencies in the intrinsic pathway. And so it's a poor substitute for a PTT if you're trying to assess some of these other things we've discussed here in the slide. You often hear them talk about mixing studies. A mixing study is done, and it seems like something a hematologist would order. A mixing study simply means that you take the patient's blood and then you add some normal plasma to the patient's plasma and you repeat the study. So if a patient has a factor deficiency, so for example they're hemophiliac and they don't have any factor VIII, well then if I add some normal plasma to their plasma and repeat the study, then the study should be normal. But if the patient has some kind of inhibitor or an anticoagulant, like the lupus anticoagulant, then the study won't normalize because they have something that's actually inhibiting coagulation. So that's what a mixing study means. We can also assess patients' fibrinogen levels. A normal level is 150 to 400 milligrams per deciliter. Patients usually start having problems when their fibrinogen gets below 100. And things like DIC will deplete your fibrinogen, whereas stresses will increase your fibrinogen. So sickness, infection, surgery will all increase your fibrinogen. And we'll talk about this more later on when we talk about DIC. You can measure fibrin degradation products, FDPs or FSPs, and this looks at the cross-linked and the uncross-linked fibrin that's floating around in the circulation, which might be a sign that there's a lot of coagulation activity going on. And then people look at D-dimers and cross-linked fibrin, which tells us that there's a mature thrombus, and that might be indicative of a PE or a DVT or even a sign of DIC. Some of you may have been exposed to thromboelastography, also known as a TEG. A related technology is called rotational thromboelastometry, or a ROTEM. And I'm just going to describe very briefly what the mechanism behind this laboratory study is. The idea is that there's a cuvette, a little cylinder, and we fill it with blood. And the cylinder, you can see, has sort of a core, so all of the blood is in this ring. There's a piston which rotates around and around. There's a little torsion wire which can be used to measure how much torque is being put on that wire, and a recorder that measures that torque. So we put the blood in and we start this thing spinning. And we measure how long does it take until fibrin strands start to form, which makes this inner core start to stick to the walls of the cuvette, and more torque is required to spin this piston, until finally there's so much fibrin that the whole process comes to a halt. And the way this is graphed is in this diagram over here. We see how long does it take. See, this basically, the width of this figure here tells us how much torque needs to be applied in order to turn this piston. So at first it's just clean, there's no fibrin at all, and you don't need any torque in order to spin the piston. And then after a certain period of time R, we start to form enough fibrin strands that you need a little bit more effort to spin this piston, because the fibrin strands are starting to slow down the rotation. And this is designated by a more and more widening curve over here. And we can measure the angle here, which shows how fast it's widening. We can measure K, which is the speed of clot formation, until we get to a maximum amplitude, when it's hardest to spin that piston. And that tells us about how strong the clot is. And then eventually, if you give it enough time, it's whole blood, it's human blood, it will start to break down the fibrin strands, and it will get easier to rotate the piston again. And this teardrop shape TEG comes to a point. So all of these different variables can be used to talk about different components of the coagulation cascade. So for example, if this were a normal thromboelastogram, this diagram here shows hemophilia, where the onset of clot formation is significantly delayed. And then looking at this very elongated teardrop shape, we see that it takes a very long time before a substantial clot is able to be formed. Thrombocytopenia, a low platelet count, is a very different looking TEG, where the time to formation of clot may be a little bit longer, but what we see is that the clot can't get a really good, strong clot, and that's because of the platelet deficiency. On the other hand, patients who have a fibrinolytic disorder may have a prolonged clot formation, but once they form a clot, it's broken down very quickly. The clot isn't sustained for very long. And finally, on the other end of the spectrum is hypercoagulation, patients who very quickly form a clot, and the clot is very strong and very intense. I've seen diagrams like this on board exams, where they will ask you which diagram is most consistent with a clinical scenario that they've given you. So now we've talked about all of the different laboratory studies that are available to us. Let's start talking about some thromboembolic disorders, disorders where patients are more likely to form a clot. The first category would be congenital disorders. Most commonly, we talk about factor V Leiden, which is really just activated protein C resistance. Remember, we said activated protein C breaks down clot, and so these patients are unable to break down clot by that pathway. This is actually the most common hypercoagulable mutation. About 5% of Caucasians carry it, and it's autosomal dominant. And what happens is that factor V becomes resistant to being degraded by activated protein C, and that's the factor V Leiden. There are other congenital problems, so a person could actually have a protein C or a protein S deficiency. This is one step earlier than the factor V Leiden mutation. And these patients develop a lot of venous clots like PEs or DVTs or even a stroke. The treatment is just to anticoagulate them forever. That's true for factor V Leiden as well. And remember, in these patients who don't have any protein C or protein S, they actually have some risk for what's called warfarin limb necrosis. And this happens when you start someone on Coumadin, on warfarin, without any heparin on board already. So actually, the little bit of protein C and protein S that they have, when you give them Coumadin, it inhibits protein C and protein S first. And so they actually become hypercoagulable before they become hypocoagulable. And so in their deficient state, these patients can actually get thrombus if you start them on Coumadin without having put them on heparin first. Finally, on this slide, patients can have an antithrombin 3 deficiency, or they can have a prothrombin mutation. So there are lots of ways that patients can have thromboembolic disorders. These patients usually present with, like we said before, a clot like a PE or a DVT, or they may present with a large number of unexplained miscarriages, and that would lead to a workup looking for one of these diagnoses. Now, there are many acquired thromboembolic disorders, and the risk factors, as many of you know, include being inactive or immobilized, patients with fractures or post-surgical. Malignancy is a very strong risk factor for thromboembolic disorders. Oral contraceptives and estrogen in general and pregnancy, all of these things put patients at risk for developing clots. The antiphospholipid antibody, or the lupus anticoagulant, or the anticardiolipin antibody are all similar conditions. These are all antibodies that can increase the activity of the embolic side of the pathway. The antiphospholipid antibody is often found in patients who have Guillain-Barré disease, or lupus or migraines, scleroderma, Sjogren's disease, Wegener's granulomatosis, a lot of autoimmune diseases. These patients are often found when they show up with an unexplained elevated PTT. And this often happens as part of their preoperative screening, and the PTT is elevated, it's 50. And that gets everybody nervous. They can't have surgery because they could bleed. Now, never mind that the patient has never had a single episode of clinical bleeding. And this is often the antiphospholipid antibody or the lupus anticoagulant. Now, don't be fooled because they don't have lupus and they aren't anticoagulated. In fact, they're at increased risk for thrombus. And especially during pregnancy, these patients can develop thromboembolic disorders. So how do we go about working this up? Well, a mixing study is done. That's what the hematologist will order, where they take a 1-to-1 mixture of the patient's plasma and control normal plasma. And if the PTT gets normal, then we know that they really have a problem with their PTT. There's something wrong with their intrinsic pathway. But if the patient has lupus anticoagulant, the PTT will remain prolonged, and that's because there's something in the patient's plasma that's actually inhibiting the PTT. There's a test called the dilute Russell Viper venom test, which can actually verify the diagnosis. So that might be some board's trivia for you. But in general, patients with lupus anticoagulant are safe for surgery. They don't have any increased risk of bleeding, and if anything, you might want to think about giving them some extra precautions to prevent thrombus. Patients who have hyperhomocystinemia due to various congenital mutations, or any other problem in their B6, B12 folate pathway, these patients can also have increased risk of thromboembolic disorders. We know that hyperhomocystinemia is associated with increased risk of coronary thrombus, for example. So we've covered a lot of different diagnoses here, and I'll pause for a moment so you can consider any questions that you might have that you'd like to discuss, and then we'll move on. So we've talked about thromboembolic disease, and now we're going to move on to disorders of hemostasis, disorders of coagulation. These can also be broken down into congenital and acquired diseases. The congenital diseases and acquired as well can be broken down into primary and secondary hemostasis disorders. So we have disorders like Bernard-Soulier disease, which involves the platelets, or Glanzmann thrombasthenia, von Willebrand's disease, which we'll discuss in more depth, as well as problems with the coagulation cascade, hemophilias, amyloidosis, and other factor deficiencies. Pretty much any factor you can think of can be deficient due to a congenital problem. And then people can acquire disorders of hemostasis, either in the platelets, like thrombocytopenia or platelet dysfunction, as well as secondary hemostasis due to various problems with diet, liver, or other things that we're going to discuss in more detail later on. Let's discuss von Willebrand's disease, which is the most common hereditary bleeding disorder, affecting about 1% of the population. These patients present with bleeding often from mucosal surfaces, so from the gums, from the nose, unusually heavy periods. And if you check their coagulation studies, so you look at the PT, PTT, and the platelets, they may all be normal. There are several types of von Willebrand's disease. I would like to tell you that you don't have to memorize this kind of stuff, but unfortunately, you do see these questions on the boards. So I'm going to go over all of them and try to highlight what I think is most likely to be found on a board's exam. So type 1 disease is the mildest and the most common. This is where they have a deficiency in the von Willebrand's factor. This is autosomal dominant, but it's actually so mild that some patients may not even know that they have this disease. And the treatment is DDAVP, which we'll discuss again later on. Then there are a number of different type 2 diseases, and they're all various dysfunctions. It can be a dysfunction of platelet adhesion, which is type 2A or type 2M, and these are treated with DDAVP again. I'm going to skip down to type 2N, which is decreased binding to factor 8, and it looks a lot like hemophilia. The one I think you definitely need to be aware of is type 2B, where there's actually increased platelet binding. And so if you treat these people with DDAVP, you can actually cause thrombocytopenia. And so it's very important on board exams to be aware that von Willebrand's disease type 2B should never be treated with DDAVP. Finally, there's type 3, which is an actual deficiency in von Willebrand's disease, but this is much more severe. And these patients have spontaneous hemorrhage. Fortunately, it's autosomal recessive, which is probably why it's so clinically uncommon. And you actually have to treat these people with factor concentrate so they can get von Willebrand's disease. So they can get von Willebrand's factor infused into them. Now we can talk about hemophilia. Hemophilia A is a deficiency in factor 8. Remember that factor 8 and von Willebrand's factor are normally bound together, and so we should clarify that patients with hemophilia A have normal von Willebrand's factor, but they have no or diminished factor 8. This is an X-linked recessive genetic disease, so remember that would mean male patients are much more likely to be clinically affected than female patients, because a male patient would only need one mutated copy, whereas a female patient would need 2. These patients present with deep tissue bleeding, bleeding into joints, bleeding in their urine. Their PTT will be abnormal, but the PT and bleeding time should be normal. Now, a normal factor 8 serum concentration, if you measured it in the lab, would be 100 units per deciliter. And if you look at patients who have hemophilia A, mild disease has anywhere between 5 and 30% of normal levels. Moderate is about 2 to 5%, and it's not really severe until they have less than 1% of normal levels. So you can see there's an awful lot of redundancy in this factor. So if the disease is mild, you can actually give them some DDAVP because that will cleave factor 7. It says from DDAVP, I think that's a typo. It cleaves it from von Willebrand's factor. So these patients have some factor 8, they just don't have enough, and the DDAVP will help accelerate that process. You could give specific factor concentrates, so there is recombinant factor 8 available nowadays, and we can use that. When these patients are out and about on the street, the chronic goal is just to get them above 1% of normal, ideally about 3%. So actually, patients with hemophilia are allowed to walk around with a moderate degree of disease. But when they come in for surgery or they experience an injury, then they need to be treated. Usually you give them 50 units per kilogram of factor 8, and your goal is to get them up to 100% factor levels. And that's the case anytime there's an injury or an anticipated surgical procedure. It needs to be redosed every 8 to 12 hours. And if the treatment is so urgent that you don't have time or means to get factor 8, other alternatives are to treat with prothrombin complex concentrates or with factor 7A. And we'll talk about that a little bit later on in the chapter. There is a hemophilia B. It's pretty much identical to hemophilia A, except that it's a factor 9 deficiency instead of a factor 8. This is more commonly found in Ashkenazi Jewish patients, but it is once again X-linked recessive. We treat this with recombinant factor 9 instead of factor 8, and again we want them to be at 50 to 100% levels before having surgery. This factor has a longer half-life than factor 8. There is something called hemophilia C, which is a factor 11 deficiency. It's autosomal recessive and it's pretty rare. People can acquire hemophilia if they are unfortunate enough to develop antibodies to factor 8. And unfortunately for our hemophiliac patients, a lifetime of being exposed to these factor concentrates can lead them to develop factor inhibitors and factor antibodies. And up to 30% of our patients will develop an antibody to factor 8 due to all of the different concentrates they've been given. Take a moment to consider any questions you may have, and then we'll move on to the next section. So now let's talk about acquired coagulopathies. So patients can have problems with their primary hemostasis, so they can become thrombocytopenic, and that can be due to a problem in any step of the pathway. Patients can not produce adequate platelets. The platelets can be consumed or destroyed. They can be diluted or sequestered into various organs. Patients can have dysfunction of their platelets, so they may have a normal platelet count, but the platelets aren't working properly. This can happen in our renal failure patients who have too much urea in the blood, and uremia can cause platelet dysfunction. Medications can cause it, including antiplatelet medications like Plavix, COX inhibitors like ibuprofen, other GP2B3A inhibitors, Hespan, various herbal medications can all cause platelet dysfunction. And even liver disease, although we think of it as affecting coagulation factors, liver disease will cause thrombocytopenia and impaired platelet function when it becomes significant enough. People can also acquire secondary hemostasis coagulopathies. For example, vitamin K deficiency. Vitamin K is acquired in our diet. Vitamin K1 is in the leafy green vegetables. Vitamin K2 is actually synthesized by the bacteria in our intestines. So when a patient takes oral antibiotics and upsets that normal flora in the GI tract, and the extreme of that would be patients with sterile gut, as well as patients who have liver disease, who are on TPN, who have hyperperistalsis. All of these patients are at risk of developing vitamin K deficiency. And the treatment is simply to restore that vitamin K, and it can be given IV or IM, although there are some risk factors with IV vitamin K causing hypotension or allergic reaction. It can also be given orally, and it usually works in about 6 to 8 hours. In addition to vitamin K deficiency, people can have immune causes of their secondary hemostasis coagulopathy. So patients can actually develop, as we said before, an antibody to a clotting factor. And at that point, the clotting factor is taken out of the pathway, and they develop a coagulopathy. Patients who have liver disease are at risk for coagulopathy from a large variety of different pathways. Liver disease, as we said a moment ago, can affect your platelets, your coagulation, and even your fibrinolysis. So the patients can become thrombocytopenic and have poor platelet function. They can have decreased production of coagulation factors, which are mostly made in the liver, but they could also have decreased production of anticoagulants, so you never know for sure which way the pendulum will swing for a given patient. Patients may have increased fibrinolysis because they can't clear TPA, which is done in the liver, and that puts them in a state of sort of like persistent low-grade DIC. So what does all of this add up to? Well, you take a patient with liver disease and their PT and PTT may actually be pretty rotten and may overestimate the severity of their coagulopathy. And in fact, the patient may have elevated PT and PTT but still be at risk for thrombosis. And so patients with liver disease can be very complicated and can do unexpected things based on the rudimentary lab studies that we've discussed right here. Now we're going to talk about DIC, Disseminated Intravascular Coagulation, which is best defined as a consumptive coagulopathy, which is probably just a fancy way of saying clotting and bleeding. Right? They use up all of their clot and then they start to bleed. So the clotting means that something pathologic has activated their coagulation system and impaired their ability to degrade clot, and they start to deposit clots. They deposit thrombi all throughout the circulation, which is bad, but especially in the microvasculature. So you get tissue ischemia in the kidneys and in the lungs due to these clots. The patients also develop problems with clinical bleeding. Because they've created so much clot, they actually deplete their factors and their platelets. The platelets can be entrapped, they can be consumed in these meaningless clots. They deplete all of their coagulation factors. They activate their fibrinolytic system, and these fibrin products, these breakdown products, go and inhibit further clotting, and the patients bleed and bleed. Usually DIC is created by some offending condition. It could be sepsis. There are a number of obstetric complications that can lead to DIC, most commonly an amniotic fluid embolus or a fetal demise, but placental abruption and preeclampsia can also cause DIC, as well as a number of other insults like traumas, burns, malignancy, hemolysis, or even just acidosis or hypoxia. So we should always be on the lookout for DIC in patients who develop unexplained changes in their hemostatic mechanisms. Clinically, we see first petechiae or frank ecchymoses all the way up to bleeding. The labs will show elevation in both the PT and the PTT. Platelet count will be down, fibrinogen will be down. Fibrin degradation products should be way up, as well as the D-dimer. But don't be fooled by this fibrinogen level, because the fibrinogen could actually be kind of normal, and normal isn't normal, because in a case of sepsis or burn or surgery or stress, the fibrinogen level should be elevated. And so normal is actually low. And there is a scoring algorithm, which is in your text, which can be used to help make these diagnoses. The treatment for DIC is really to treat the underlying pathology. So if there is retained placental product, it needs to go out. If there's sepsis or infection, it needs to be treated. Otherwise, all we can really do is supportive care. So try to keep the platelet level above 50,000, give appropriate dosing of supplemental FFP or fibrinogen, try to keep the fibrinogen above 100, and usually this is done with cryoprecipitate, which has fibrinogen and factor VIII, and it's a pretty low volume, so you don't volume overload these patients. Now, people have proposed quite a number of other treatments, including heparin, or low molecular weight heparins, or activated protein C. There really isn't enough evidence to support any of these as part of routine care at this point, and we don't usually see this being done when we have patients at our institution who develop DIC. We've covered quite a lot in this section as well, so it's time to stop. Please let me know if you have any questions or comments or concerns, and we'll pick up with the next video for the rest of the material.